Pleasure of introducing yet another internationally trained physician. So he did his undergraduate in Ontario, Canada, a medical school in the Dutch Caribbean, and then a fellowship at a family medicine residency at the University of Pittsburgh. Actually practiced as a family medicine physician for about 6 years before realizing that he really loved seeing and managing headache patients. And so has been with us here at Tourlas for the last year doing a headache fellowship. So he's going to present this afternoon on headache.
Thank you for that introduction. So I have no disclosures. Starting off with the learning objectives. So by the end of this lecture, the goal is that you should feel more comfortable evaluating a patient that presents with headache to your clinic. You should be able to identify the headache red flags. You should be able to identify the indications for brain imaging. You should be able to diagnose tension-type headache and migraine. And you should feel more comfortable starting acute and preventive treatments for migraine. So why is headache important? So the reason why headache is so important is it's in the top 10 presenting complaints of why patients present to a primary care office. I'm sure all of you in this room have seen a headache patient. It's the most common presenting complaint to general neurology. Migraine is the first cause of disability in people aged 15 to 49. It's ranked second in all-cause list, being responsible for 5.6% of all years lived with disability in the world. And the quality of life of pediatric migraine sufferers is similar to children with rheumatoid arthritis and cancer. Due to that, these children end up missing school, they miss social activities, they miss extracurricular activities. And it can also be tough on the parents. They may have to miss school, or they may have to miss work because they're at home taking care of their loved ones. So I want to start off with a case. 15-year-old male presents to your primary care office with a chief complaint of headache. So how are we going to approach this patient? So we always go back to basics, start off with the history and physical. So going over the history, he's a 15-year-old male, grade 9 student, competitive soccer player. Headaches initially began about 3 years ago. Frequency at that time was 1 to 2 headache days a month. For the past 1 year, headache frequency has worsened to about 1 to 2 days a week. He denies any inciting events that may have caused this worsening. Headaches last for 2 to 4 hours, and his longest headache has lasted about 12 hours. They're located bifrontal and bitemporal. The quality is throbbing and pulsating. Movement makes his headaches worse, and they are activity limiting. He prefers to lie down in a dark, quiet room during attacks. There's no positional component to his headache. Headaches cannot be precipitated by a Valsalva maneuver. Associated symptoms include photophobia, phonophobia. He has some nausea, but no vomiting. There's no aura. Triggers include skipping meals, not sleeping enough. He has a past medical history of motion sickness and colic as an infant. He has no surgical history. Looking at his family history, his mom has migraine. And looking at his social history and regularity of schedule, he's sleeping about 6 to 10 hours a night. He doesn't drink enough water when he doesn't play soccer, maybe 8 to 16 ounces a day. Remaining social history is unremarkable. Looking at his medications, he states he's tried Tylenol and ibuprofen. That initially helped his headaches, but now it's no longer helping and he's no longer using these meds. Going to his physical exam, his vital signs are normal. Looking at his weight, he's in the 70th percentile for his age. And his physical exam is completely unremarkable. Now, it's very important that when you evaluate a headache patient, you do a thorough neurological exam, assessing his mental status, cranial nerves, motor, reflexes, coordination, sensation, and gait. It's also very important to do a fundoscopic exam, as this allows us to indirectly assess for raised intracranial pressure by looking for papilledema. So what are the next steps for our patient? Do we need to order blood work for him? Do we need to order brain imaging? Or can we give him the diagnosis just based on the history and physical that I presented? So I'm going to start off by going over how do we classify headache disorders. So we classify headache disorders using the International Classification of Headache Disorders, and it's currently in the 3rd edition. It's available online. The website is up front there. I recommend that you kind of bookmark this and save this and use it as a reference. Now, headaches are classified into 2 main categories. We have primary headache disorders, and we have secondary headache disorders. The primary headache disorders include migraine, tension-type headache, trigeminal autonomic cephalgias, this includes cluster, and other primary headache disorders. Looking at our secondary headache disorders, these are headaches that are as a result of another condition. So it could be headaches due to trauma, headaches due to a vascular cause, intracranial pressure problem, due to a neoplasm, epilepsy, infection, etc. Now, whenever you evaluate a headache patient, we're trying to rule out secondary causes of headache, because if this is not diagnosed in a timely manner, it can be detrimental to the patient. So going over the red flags can help with that. A mnemonic that may help you remember what things to look for is SNOOP-Y. So the S stands for systemic signs or symptoms. So assessing, does your patient have fever, chills, weight loss, night sweats? Do they have any comorbidities that could be contributing to their headache? Are they on any new medications? The N stands for neurological signs or symptoms. Do they have an abnormal neurological exam? Is there true papilledema on their exam? The O stands for onset sudden. So did their headache go from 0 to 100 within 10 seconds? Are you concerned for a thunderclap headache? Second O stands for onset in sleep or early morning. Are headaches waking the patient up in the middle of the night? Do they have headaches first thing in the morning when they get up? There's 8 Ps. In a patient who has headaches, has the pattern changed? Are they more painful now? Has the frequency changed? Are they getting worse? Or is the patient presenting with new headaches? Are headaches precipitated by Valsalva maneuver? Can cough induce a headache? Sneezing? Exertion? Is there a positional component to their headache? Does laying down or standing up trigger or cause headaches or make their symptoms worse? Is there a lack of family history of headache? Is your patient pregnant? You may think of preeclampsia. Is their presentation atypical for a primary headache disorder? Or did headache occur after a post-traumatic event? And Y stands for younger. Do you have a younger patient presenting with a new headache? By younger, some studies say less than 6 years of age, and some say less than 7. Now, traditionally, you may have learned that occipital pain was considered a red flag in pediatrics. However, with current research and literature, there does not appear to be any increased association of intracranial pathology when you compare that to headaches in other locations. So going back to our patient, his headaches began 3 years ago, so there's definitely some chronicity to his headaches. His headaches did get worse. However, this has been going on for over a year, so they're still chronic. He denies any inciting events that may have caused his headaches to worsen. There's no positional component to his headaches. They can't be precipitated by Valsalva maneuver. His mom has migraine. Looking at his physical exam once again, it was completely normal. So based on that, I can comfortably say there's no red flags. So next question we need to ask, does he need brain imaging? So the American College of Radiology and the American Headache Society recommend against imaging patients meeting criteria for tension-type headache or migraine, having no red flags, and a normal neurological exam. Now, how do we classify our primary headache disorders? So this is broken down into migraine, tension-type headache, trigeminal autonomic cephalgias, which includes cluster, and other primary headache disorders. Due to time, I'm just going to be focusing on migraine and tension type. So tension-type headaches are the most common primary headache disorder. However, they generally don't present to a primary care provider's office just because these headaches tend to be less intense and less debilitating. Now, these headaches are diagnosed by a headache lasting 30 minutes to 7 days, and they need to have at least 2 of the following criteria: bilateral location, pressing or tightening quality, mild or moderate intensity, not aggravated by routine physical activity, such as walking or climbing stairs, and both of the following: no nausea or vomiting, and photophobia or phonophobia, but not both. Now, moving on to migraine. To make the diagnosis of migraine, a patient needs to have at least 5 attacks, fulfilling the criteria below. So these are headache attacks lasting 4 to 72 hours. This is untreated or unsuccessfully treated. Additionally, we also include time sleeping. What do I mean by that? So say you have a patient who presents to your office and he says, when I get my headache attack, I usually take a nap for 2 or 3 hours, and then when I wake up, my headache's gone. So that 2 to 3 hours sleeping we include in the attack duration. Now in pediatrics, migraines tend to be shorter, so they need to last at least 2 hours. And then they need to have at least 2 of the following criteria: unilateral location. Now in pediatric patients, they do tend to be bilateral. Pulsating quality, moderate or severe pain intensity, aggravated by or causing avoidance of routine physical activity. So when they walk or climb stairs, it makes their symptoms worse. And at least 1 of the following: nausea and or vomiting, and then photophobia and phonophobia. Now in young children, if you ask them, does bright lights bother you when you have a headache, or loud noises, sometimes it's hard for them to answer that question. So in the younger children, we sometimes infer this from their history. So if mom tells you, when Johnny has a really bad headache, he goes, lays down in a dark, quiet room, we can infer that that patient has photophobia and phonophobia. Now, migraine can present with or without aura. The prevalence of aura in children is low. It's about 3% in children aged 3 to 7 years of age, and that rate slowly increases as the child ages to reach the adult prevalence of 25 to 33%. An aura generally begins within an hour before the headache pain begins. However, sometimes an aura can start as soon as the headache pain starts. So going back to our patient, I just wanted you guys to show you the history once again. What would you say his primary headache diagnosis is? Does he have a tension type headache? Does he have migraine? Does he have a trigeminal autonomic cephalgia? Or does he have another primary headache disorder? So I would diagnose this patient with migraine. So now how are we going to treat our patient? So we treat our patient multimodally. We start off with self-management and lifestyle modifications, talking about identification of triggers, making sure our patients are exercising, making sure they're drinking enough water, making sure their sleep is optimized, and making sure they're eating 3 meals a day and not skipping any meals. Next, we talk about complementary and alternative interventions, such as nutraceuticals, physical therapy, acupuncture. Sometimes we have to add on pharmaceutical medications. These can be used to help acute attacks or to help prevent migraine. And then sometimes we need to add on psychological interventions, such as relaxation, biofeedback, cognitive behavioral therapy, or hypnosis. Now, with all of my migraine patients, I stress regularity of schedule. So this means regular sleep and waking times, and this includes both on weekdays and weekends. Regular exercise. I recommend to all my patients that they exercise at least 30 minutes, 5 days a week, and this is aerobic exercise. Regular meals, eating a protein-rich breakfast within 30 minutes of waking, and not skipping meals throughout the day. Staying hydrated. In general, I tell my patients to drink 1 ounce for every kilogram of weight. And then I also provide all my patients this link, so if they want more information about healthy habits. Now, say our patient gets an acute migraine attack. How are we going to treat them? So the American Academy of Neurology, in conjunction with the American Headache Society, upon reviewing the literature, has come up with guidelines to help with this. So we use 3 classes of medications. That includes simple analgesics, or NSAIDs, triptans, and antiemetics. So for a patient who has a mild to moderate headache, we generally tell them to take an NSAID. I generally like to use naproxen. The reason I prefer naproxen is because it is a longer acting NSAID, and it has less risk for medication overuse headache. If your patient wants to use ibuprofen, that's fine. It's just that if they're using the ibuprofen more than 14 days a month, it can lead to medication overuse headache. And it's very important, whichever NSAID you use, you optimize the dose based on their weight. Now, if your patient has a moderate to severe headache, I tell them to take the NSAID in addition to add on a triptan as well. I generally start off with sumatriptan, and then based on their weight, I have the dosages there. Now, if within 2 hours their headache's not resolved, they can repeat the dose. Now, with triptans, I always counsel my patients to not use more than 9 days a month, because if they do that, it can increase the risk of medication overuse headache. Now, if your patient has nausea and vomiting present with their headache, I tell them to add on an antiemetic. I generally prescribe ondansetron. They can take it every 8 hours. However, I do counsel them on not using it more than 4 days a week because it can increase the risk of constipation. Now, say your patient calls you during the day or in the middle of the night, and they're like, "Doc, I have a really bad headache. I took my NSAID, took my triptan. It's still not helping. What can I do?" So at that point, I have my patients take a dopamine antagonist drug with over-the-counter Benadryl. The reason I have them take over-the-counter Benadryl is because sometimes dopamine antagonist drugs can cause dystonic reactions in patients, and the Benadryl helps prevent that. I generally like to use Compazine with over-the-counter Benadryl, and I have them take it every 8 hours. Now, I do tell my patients to not use it more than 3 times a week due to that increased risk of dystonic reactions. Now, this is just a summary table, just kind of going over and combining everything that I reviewed with you guys on the previous slides. Now, the next question you may have is, when do we start preventive treatment in our migraine patients? So you should consider and discuss preventive treatment in pediatric migraine patients who present with the following: 4 headache days a month, or 3 to 4 migraine attacks a month for more than 3 months. A moderate to severe migraine-related disability. We use the PED-MIDAS to assess for this. It's a 6-question survey, and we're looking for scores over 30. Or if the patient has medication overuse, if they're using triptans more than 9 days a month, or if they're using over-the-counter analgesics or NSAIDs more than 14 days a month. Now, it's very important that with any migraine preventative, you let your patients know that it's not going to work right away. It can take 6 to 8 weeks to see the full effect, and it's very important that they take it every day, not skip doses. So when it comes to migraine prevention, I generally start out with nutraceuticals. These are vitamins and minerals that have been shown to help prevent migraine. The ones with the most evidence are riboflavin, or vitamin B2, magnesium, melatonin, or CoQ10. I generally start one at a time, and after the patient has failed 2 of them, I'll then move on to prescription medications. So when it comes to prescription medications, there's many different classes of medications that we can use to help prevent migraine. We can use anti-epileptic drugs, such as topiramate, antidepressants, such as amitriptyline, venlafaxine, beta blockers, such as propranolol, other antihypertensives, such as verapamil, other classes, such as memantine, cyproheptadine, neuromodulation devices, trigger point injections, nerve blocks, and Botox. So here's a list of the common medications that I generally prescribe and use. One question you may ask is, how do I decide which medication to start in my patient? So whenever I'm seeing a migraine patient, I try to look at the whole picture and look at their comorbidities. Based on that, I can decide which medication to start. So say my patient has problems falling asleep at night. I may start off with amitriptyline, just because it can cause sedation. If I have a patient who is overweight or obese, I may use topiramate, as this can cause decreased appetite and lead to weight loss. Say I have a patient who has some depression, I may start venlafaxine. Or if I have a patient who is a little bit anxious, I may start propranolol. Now, I briefly wanted to just talk about treatment for tension-type headache. Like I said, these headaches tend to be more mild and less debilitating, and they generally don't present to your office. But if they do, I treat them similarly to migraine. So I always talk about that regularity of schedule. For acute attacks, I tell them to use simple analgesics or NSAIDs. And then if they need prevention, I use the same migraine preventives that I just reviewed. At the end of my visit, I always go over a headache diary with all my patients, and I instruct them to complete this and bring it to their follow-up appointment. I like to use the colors of the stop light. So a red headache is a really bad headache. They just want to lay down in a dark, quiet room. A green headache is they have a headache. It's not bothersome. They can go about their everyday activity. And a yellow headache is somewhere in between. Here's just a sample of 2 patients. So both patients have the same number of total headache days each month. However, one patient has 1 headache a week, whereas the other patient is having 2 headaches a week. So these diaries allow us to see patterns, trends, and we can actually see how debilitating these headaches really are. So when should we refer a patient to neurology? So if you have a patient who has any new focal neurological deficits, if there's concern for meningitis, if there's true papilledema on exam, if it's a thunderclap headache, or if it's a post-traumatic headache and there's concern for a bleed or a dissection, I would send that patient to the ER. If there's any other red flags, I would refer to neurology. Now, say you have a patient that you're not clear is this migraine. However, the neuro exam is completely normal and there's no red flags. I would say it's okay to treat this patient like migraine, and as long as there's no contraindication to the medications you use, you can reassess the patient at a follow-up appointment in 2 months. And if they're getting better, great, maybe it is migraine. And if they're not, you can refer to neurology. Now, if you have a patient where headaches don't appear to be tension type or migraine, I would refer. Patients that are resistant to treatment. If there's concern that your patient has an atypical aura, or if your patient's interested in a procedure, such as trigger point injection, nerve block, or Botox, and this is something that you don't provide in your office. So in summary, I just want to leave everyone with the following take-home points. It's very important to take a good history and perform a thorough neurological exam and fundoscopic exam when you're evaluating a headache patient. That alone can give you the diagnosis. If there are any red flags, if needed, send to the ER or refer. Or if you're comfortable doing the workup, you can do that yourself. Now, if there's no red flags and the history is consistent with tension-type headache or migraine, no further workup needs to be done, and you can start treating the patient. Regularity of schedule is very important. I stress this with all of my migraine patients. And it's very important to personalize the treatment plan based on the patient's comorbidities. There's no one-size-fits-all. Sometimes you may need to fine-tune the treatment plan based on efficacy and side effects. It's also very important to identify any undiagnosed or uncontrolled mood disorders. Not improving mood makes it very difficult to treat patients with headache. Medications plus cognitive behavioral therapy have been shown to be the most effective. And lastly, empower your patient that they will get this under control. stress the importance of compliance with preventative medications, and review the time course of treatment with your patient and what you expect to see by the time they follow up with you the next office visit. So generally, when I start a preventative option, I tell all my patients that by the next office visit, I expect to see a 50% reduction in headache. So I want to thank everyone for their time and attention. Any questions?
I have like about 4 questions.
Yeah.
The first one is the Benadryl comment that you mentioned.
Yes.
It is so clinically important to us. We see migraines all the time. You know, we recommend Benadryl all the time. And if you could please clarify in more details.
Yeah, so Benadryl is not actually helping the migraine. I've seen some providers prescribe Benadryl thinking that it's actually helping, or they think it's going to help the migraine. But the purpose of the Benadryl is more so to be prescribed or taken in conjunction with a dopaminergic antagonist, such as compazine or Reglan, just because these medications can cause dystonic reactions, and the Benadryl can help prevent that.
And the next question is, what's your logic for that protein-rich breakfast within 1 hour of waking up?
Yeah. So the reason why I counsel my patients on that is, generally most patients, they'll eat dinner around 6 o'clock, and then, they may not eat till the next morning. So definitely their sugar levels have dropped. So eating that protein-rich breakfast can kind of help maintain steady glucose levels kind of throughout the day, as long as they're eating regular meals and snacks throughout the day. So, it's very important that they're not doing prolonged fasts throughout the day.
And just a curiosity question, you don't have to answer it, but physical therapy,
Yes.
how often is it used or needed?
Yeah, so definitely when I see a headache patient, I definitely examine their scalp. I try to palpate their greater occipital nerves, less occipital nerves. A lot of patients have tenderness in that area. They also have paracervical spinal tenderness. They have tightness in their shoulders. So relieving that tension and tightness can help improve their migraine.
And the last one, what I actually do in practice for the schedule, I allow them a 1 hour kind of jet lag on Friday and Saturdays.
Yes. So I definitely, I do the same thing. So I say 1 to 2 hour, exactly, yes. There could be a 1 to 2 hour difference. We just don't want patients, during the week, they go to bed at 9 o'clock. Oh, come the weekend, I'm up now till 1 in the morning. Because definitely that can throw things off.
Thank you very much.
Yes.
Can you comment on some of the downsides of doing neuroimaging in patients that don't have red flags?
Yes. So when some patients that come to us, that are referred to us by primary care, come to us wanting a brain MRI. They say, my primary care doctor sent me to get an MRI of my brain. Now, if their neuro exam is completely normal, they have no red flags, we don't need to do that MRI of the brain. However, some patients or their parents, they want it done just to give them that reassurance because they're scared like any parent. You want to make sure there's nothing more going on. So what are the downsides to doing an MRI in someone who doesn't need it? So number one, if the patient is younger, sometimes we need to sedate that patient. Just because for an MRI, you need to sit still. If you don't sit still and you're moving around, the pictures are going to be very grainy and not clear. So right there, that sedation poses a risk to the patient. Now, say we do get the MRI, sometimes we find incidental findings, such as cysts. 9 times out of 10, these cysts tend to be nothing. They're not harmful. They wouldn't have caused any issues or problems. However, now we have this finding that we have to follow up, maybe get another MRI in 6 months. So it's leading to more imaging, maybe more sedation that the patient wouldn't have needed. And it can be, it can be scary for some patients, especially going to that MRI machine if they try to do it awake. So, that's kind of why we don't recommend getting it, just because we sometimes see these incidental findings, and sometimes we don't know what to do with them, so we just end up getting another follow-up scan, which may not have been necessary if we wouldn't have done the picture. Yes.
So MRIs, I don't mind as much. I'm like, if you have extra money, go MRI the whole body. But we have, we have mothers who will walk into the office, they open the front door and they want a CT scan for their child. We have to break our heads telling
Yes.
them, okay.
So yeah, I definitely agree. Yeah, we don't recommend CAT scans. A lot of times when a patient goes to the ER, the ER does a CAT scan. Number one, there's that radiation, especially in our young pediatric kiddos. Their brain's still developing. We don't want it to expose them to unnecessary radiation. So yes, I say no to CAT scan. If you are going to do imaging, just because you want to please mom or make mom happy, I would say order an MRI over a CAT scan, just because it's going to provide us better pictures and there's no radiation exposure.
Can you comment on caffeine?
Yes. So definitely there are some studies out there where, yes, caffeine can help. The problem with caffeine is it can lead to medication overuse headache. So I generally don't use it that often. However, I may use it in certain scenarios. When patients get pregnant, we're definitely limited into what we can use in this population. There are certain other types of headache disorders, like low pressure headaches, where we use caffeine as kind of first line. But when it comes to tension type and migraine, I generally don't go for that off the bat. Yes.
I just wanted to make sure I'm right in what advice I'm giving my patients about caffeine.
Yes.
My patients with all these headaches,
Yes.
I tell them no caffeine when they're not having a headache, but when they have a headache, they can have caffeine.
Yeah, yes, you're absolutely right. So definitely caffeine can help migraine, and yes, I do have some patients that use it. The problem is, your patients who drink coffee, more so with the older patients, who are drinking coffee every day, they're at very high risk of getting caffeine withdrawal headaches. So I generally try to stay away from. But yes, a patient who's using caffeine, once a week, that's fine.
Yeah, my understanding of the caffeine issue is that it's not necessarily the caffeine, it's the lack of regularity.
Yes.
If you start taking it or stop taking it, that's when it causes problems.
Yes, I agree with you, yes.